as much as we are interested to know how the ECGs look like and what do the ECGs tell us, which is on the surface of the heart, we would like to know the same way we are interested to know what is happening inside the heart also. So when we put electrical catheters inside the heart, then we start seeing some signals, the electrical signals. And it is this interest that drove me into taking up electrophysiology. So myself, I'm Dr. Deep Chand, I'm a cardiac electrophysiologist at Kaveri Hospital, Chennai. So let us look into some basics of intracardiac electrograms. This is actually a series of lectures, but I can only cannot do justice to the whole topic. I can only give some introduction and sort of teasers of how the electrocardiograms look like. Yes, next slide. So the catheters that are placed in the heart for people who are new to electrophysiology, the catheters have a number of electrodes. So these electrodes pick up signals. There could be 4 electrodes when we call these catheters quadripolar electrodes, like one you see in the RA view in the RV apex, which has 4 electrodes, which is a quadripolar, and one catheter that we put in the coronary sinus, which is routinely a decapolar catheter, which means it has 10 electrodes. And we also place catheters, a quadripolar catheter along the his and one in the high right atrium. Next. So the signals that we generate or these electrodes pick up is a bipolar electrogram, which means 2 electrodes give rise to one signal, and this signal is a bipolar signal. So bipolar signal is basically a construct of 2 unipolar signals. Not getting into the intricacies of how a bipolar and what affects a bipolar signal, but then eventually what we see in an intracardiac EGM is a bipolar signal. As I shown here on his distal electrode, what we see are 3 bipolar signals. The first signal belongs to the atrium A, the second signal, which is a crisp and a small signal, the his signal, which is the his electrogram, and the third signal is a relatively larger amplitude bipolar signal, which is the V signal. So A, H, and V, 3 bipolar signals picked up by the his distal electrode. Next. Then the numbering of bipolar electrograms that people who start need to understand. When the decapolar catheter is placed inside the coronary sinus, so let's start with the decapolar catheter. CS12 represents the distal most electrode, or the bipolar electrode, which is the distal most, which is basically this is the lower view of the heart, where you see when the CS is placed, catheter is inside this coronary sinus. The 1-2 is what is distal most, which is at the left anterolateral or the lateral mitral annulus. And what is in the proximal most electrode, which is usually numbered likewise 1, 2, 3, 4, and then it is 9, 10. So the proximal most electrode is 9, 10. The same stands true for all the electrodes that are being used, all the signals that are constructed. So his 1, 2, and 3, 4. 1, 2 represents the distal most electrogram, bipolar electrogram, and 3, 4 is the electrogram arising from the electrode proximal to 1, 2. So the intracardiac electrograms, the things that we look at are a few things like the AH, HV intervals. So the next slide. So let me go into the introduction of these intervals. The next. Okay. So this is how an intracardiac, if one prefers to do a 3 catheter study, what you see on the top 3 rows are surface ECGs. Basically, we are used to our eyes are tuned to look at ECGs at a speed of 25 millimeter per second. But then in a electrophysiological lab setup, we see these electrograms or the intracardiac electrograms at a speed of 100 millimeter per second or 150 or at times even 200 millimeter per second. So basically, the ECG being stretched out. So the first 3 rows here are lead 1, AVF, and V1, which are basically the surface electrograms, followed by the his electrograms 1, 2, 3, 4, followed by the CS electrograms, the 5 bipolar electrograms coming from the 10 electrodes of the coronary sinus catheter, and the last one is a single electrogram, which is the single RV apical electrogram. The next. Yes, keep moving. Okay, so these are the intervals which are described, people can refer to the books even, but what students need to grasp in mind is certain intervals, basically the HV interval, because it's a very narrowly spaced out interval, which is 35 to 55 milliseconds, and anything more than 55 milliseconds, you can call it as a long HV interval, likely because of an intra-Hessian or an infra-Hessian conduction problem. And anything less than HV, we need to look for various reasons why HV could be less. And these are the other intervals. And all the intervals in an intracardiac electrogram basis are measured in milliseconds. And 60,000 by your milliseconds is equal to the heart rate. These are basics. Next. So just trying to tune your eyes to look at a few electrograms. The next. So this is a surface ECG with a first degree AV block. Next. Next. So what you see here is an AH interval of 170 milliseconds, which is longer than usual. His electrogram means the impulses already travel through the AV node, and probably in this particular case, the lengthening of the AH interval is likely because of some disease in the AV node, and hence a first degree AV block in this patient. Next. AV Wenke back. Next. So this is a classical Wenke back pattern that we see on the ECG. Next. Next. So what you see here, just have your eyes on the CS12, where you get to see both two electrograms. You see an A and a V. The arrow mark shows the A being associated to the V or connected to the V, the next A being connected to the V, the next A is getting blocked, and there is no V there. And the same pattern repeats. So this is how a Wenke back would look like intracardiac. Next. So this is a right bundle branch block, left axis, and a first degree AV block, trifascicular block in this patient. How does an intracardiac look like? Next. In AH of 100 milliseconds, and you measure the HV interval, which is 70 milliseconds in this particular case. So HV is really prolonged in this particular patient. So the patient has an intra-Hessian or an infra-Hessian conduction disease. That was again evident on the surface ECG as well. Next. 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 So here you see a HV interval which is measured as 90 milliseconds, and again it is prolonged. This is not normal. HV interval is 35 to 55 milliseconds. So this is a prolonged HV interval, which is again an example of an intra-Hessian or an infra-Hessian conduction disease. Next. So let's now look into some anti-grade, previous slide. Decremental property. AV node is like a toll gate. It will not allow traffic to get into the toll gate. It is going to stop people from entering into, or the traffic getting into, and especially if people are trying to come in fast into the toll gate, it's going to say them, please stop, take some time and then go through. It's not going to allow impulses to travel through it fast. And this property of the AV node is called decremental property. The next one. So once we deliver an extra stimuli, as you see here, extra stimuli is being delivered from CS910. The second stimulus is 450 milliseconds, which is a prematurely delivered stimulus that conducts down. Now please move your eyes to the His electrograms. The AH interval is 160 milliseconds. The next slide. So when you bring down the extra stimulus to 380 milliseconds, AH prolongs even more. From 160, now it has prolonged to 210 milliseconds. This is what I was mentioning as a decremental property of the AV node. This is one thing that all basics students need to remember, something called a decremental property, which always suggests that we are dealing with something related to the AV node. The next one. Next one. Let's get into the refractive periods here now. So again, a premature extra stimulus being delivered at 370 milliseconds. In the background of a drivetrain of 600, then AH prolongs to 260 milliseconds. The next one, and then the next impulse, as you see in the CS electrograms, 280 milliseconds. You see some atrial EGMs in the CS EGMs, CS catheter, but then it does not get conducted down to the ventricle. So this is because the AV node, or probably the impulse at that particular 280 milliseconds, has reached the effective refractoriness of the AV node, and hence the gate blocks, the toll gate is closed. It is not ready to allow any more traffic inside. So this is called the AV node effective refractory period. The next one. Previous. So And here, even more premature stimulus at 250 milliseconds does not capture the atrium even. You see in the CS electrograms, there are no atrial electrograms in the CS, which means now the atrium has started becoming refractory and there's no impulse, or atrium is not ready to accept any more impulses or any more electricity, and it cannot generate an impulse because it is an atrial effective refractory period. Next one. Next one. So during right ventricular pacing, as you see, the pacing is from the RV apex, which is the bottommost row, and as you see on the surface ECG, you have an LBB pattern on V1 because we are pacing from the right ventricle. The way the impulse gets conducted to the atrium is from CS910 to CS12. So the atrial activation pattern along the mitral annulus is important insight to the electrophysiologist. Here, the atrial activation is from 910 to CS12. So mitral annulus is getting activated from proximal to distal, which is from medial to lateral. So this is normal concentric atrial activation pattern. Next one. Next. 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 So what happens, you see a concentric atrial activation pattern here, and you have a VA interval of 160 milliseconds when you put a premature stimulus at 320. The next. So at a little more premature stimulus at 250 results in the prolongation of VA to 210 milliseconds. How did that prolongation happen? We saw previously any prolongation in the intervals because of a premature stimulus is likely because of a tall gate, in which case, in this case, it's probably the AV node which is blocking the impulses which is going retrograde. Hence, this sort of a conduction pattern is called a concentric and a decremental conduction pattern, which is very much suggestive of probably the retrograde impulse traveling up the AV node and into the atrium. Next. The next. And here, the impulse fails to capture the ventricle. You see on the surface ECG, there is no QRS formed at all. That's because the ventricle became refractory, and this is called ventricle effective refractory period. Next. Next. Okay. So next. Okay. As you see in the schematic here, I'm not getting into the basics of AV and RT, but then unidirectional block in one of the dual AV node pathways, stops a re-entry circuit, but then the unidirectional block is removed, and what happens is a slow and a fast pathway causing a small re-entry circuit in and around the AV node, which is basically what we call as an AV NRT. A typical AV NRT is when the antegrade is slow and retrograde is fast. If it is otherwise, it is atypical AV NRT. Next one. So what we had premature stimulus at next one. Next. Next. A premature stimulus delivered at 450 milliseconds, you see a AH of 160. The next one. 380 milliseconds, you see an AH of 210. This is a normal decremental property of the AV node. The next one. You bring down the premature stimulus by 10 milliseconds, the AH astonishingly jumps by another 50 milliseconds. In this case, which is AH is 260. From 210, it became 260 with only a 10 millisecond decrement in the atrial extra stimulus. This is what we call as an AH jump. This can happen only when AV node has two pathways in it. One pathway is conducting. Normal decremental property does not allow it to increase the intervals by more than 50 milliseconds. But if it happens, it is because there are two pathways sitting inside the AV node, and hence you see an AH jump here. Next one. The next one. Yes. So what happens here is that antegrade slow pathway conduction gets back through the fast pathway and has resulted in an echo beat. The next one. And in this case, the next, there are two echo beats that are formed here. And the next one, the next one, yes. So what happens here is a tachycardia has been initiated. A tachycardia, as you see, all the V electrograms and the atrial electrograms on the CS catheter are in line with the surface ECG, what we call as an A on V tachycardia. For the naive eyes, it is good. This is how I learned electrophysiology. Any A on V tachycardia, I would be happy because at least I know that I have diagnosed one tachycardia. There could be other reasons, but I know that, okay, I'm dealing with some typical AV NRT here. So all you see in a typical AV NRT is all the electrograms getting lined up. That is because one traveling down the slow and one traveling up the fast. Next. 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 That's how the re-entry circuit works for AV NRT. Next one. Next one. So this is the AV NRT, typical AV NRT, which is basically an AV on V tachycardia, but all the electrograms are lined up with the surface ECG complex, which is quite easy to identify. Next. In presence of a pre-excitation, next.
You might have to be little.
Yeah. Next. As you see, there's some evident pre-excitation. This is one of the examples when HV interval is very less. As you see, only 10 milliseconds here. In fact, it's on the negative side. Next one. And here what happens is, during the tachycardia, what they are doing is RV pacing here. CS12 becomes earliest atrial activation on this distalmost electrode of CS. That can happen only when there's a pathway sitting on the left antral lateral mitral annulus. That's happened here. That's the lateral pathway on the left lateral mitral annulus that has caused this pattern, which is called an eccentric atrial activation because of left accessory pathway. Next. So, as I said, there is more into these electrograms. I think I will stop here. As I told, this is a series of lectures. I can only give some teaser on how it works. So, bipolar EGMs, the number of electrodes, intervals, AV node conduction properties like the decremental Evenki back, and we saw basics of the refractory periods, how the AH jump and the echo beats work, and basically a re-entry of those echo beats is typically AV NRT. We saw a few examples of AV NRT, orthotomic reentrant tachycardia. We didn't get into ATs and ventricular tachycardias at this point. Next. So I would invite all of you to attend the electrophysiology training village. So if you are interested into learning more into EP, it would give you greater insights on how EP and what are the complex things into electrophysiology. Thank you.